So we discussed previously the anterior compartment of the arm, the posterior compartment of the arm. Now I will shed light on the elbow joint itself, as well as the cubital fossa. And there are a lot of clinical correlates which are involved in the elbow and the cubital fossa. Just make sure you are paying a lot of attention. Okay. So if we see the diagram, this is the anterior side of the elbow joint, and this is the posterior side of the elbow joint. So anteriorly we had the medially we had the trochlea. Medially we had, so this is the medial epicondyle, this is the lateral epicondyle, and medially we have the trochlea. We can see trochlea, and laterally we have the capitulum. On the trochlea, what is basically inserting? The trochlear notch of the ulna is basically inserting at the trochlea, while the head of the radius is articulating with the capitulum. So what I said about the capitulum, that you wear a cap on the head. So the head of the radius, the cap is for capitulum. So the head of the radius, it's actually articulating with the capitulum. And if we see posteriorly, we have the olecranon process, which is going inside the olecranon fossa. It's going inside the olecranon fossa like this. And why can't there be more extension than this? Because this is the limit where the most of the olecranon process has been articulated with the olecranon fossa, and no more extension can happen. So if I talk about the elbow joint, we need to talk about its ligament. You know that muscle are attached to the bones via tendons, and bones are attached to bones via ligaments. So it makes sense that we have humerus over here. So we have humerus over here. We have humerus over here, and this is the lateral aspect. This is the radius, and this is the ulna. There must be some ligaments which are joining all of these bones. Yes. So the first ligament that we'll talk about is the ligament which joins the ligament which just 1 second. So it's the ligament which joins the humerus to the ulna. So this is the medial aspect, the ligament which joins the humerus to the ulna. This ligament is called medial collateral ligament, since it's on the medial aspect. It's also called the ulnar collateral ligament. Okay, so we are done with the first ligament. There's another ligament which is present on the lateral aspect, and it joins the humerus to the lateral aspect of the radius. This is basically called the lateral collateral ligament or the radial collateral ligament. So these two ligaments actually help the humerus to attach itself to the ulna and the radius. Okay. There's another ligament which is really important, and that is the annular ligament. And that actually helps the radius to form the pivot joint with the ulna. So this is our radius, and this is our clavicle. This is the radius, this is the clavicle, and I said the radial head actually inserts itself on the radial notch on the ulna. So this is where it attaches, and you can see that the radius, the bone, it can rotate along its axis because it's a pivot joint. This is what enables the supination and pronation of the forearm. So this is where it attaches, but you can see that it can easily dislocate from here. So there's a ligament called the annular ligament. You can see over here. This ligament actually arises from the ulna. And it circles the radius. And then it again attaches to the ulna. So it starts from the ulna, circles the radius, and then again attaches to the ulna. This is how it attaches. And it helps the radius to perform the pivot motion. So the really important clinical correlate is that, and that the examiner love to ask this question, especially in step 1 exam, step 2 exam, or wherever you are studying medicine from. That is the subluxation of the head of the radius from this annular ligament. It's just a fancy term for dislocation of the head of the radius from this ligament. So you can call it subluxation or the dislocation. So how does that happen? So it usually happens in the pediatric population in younger kids. And why is that so? Because in younger kids, the head of the radius hasn't fully developed. So it is prone to get basically dislocated from this annular ligament. Also, in kids, the ligaments have more laxity. It's more flexible. So they are more prone. So whenever you are holding a kid's hand, usually we have more height and they are smaller. So what happens is that if you forcefully or abruptly pull some child's hand or the wrist, or if you swing them, or you pull the child forcefully, what can happen is that there can be displaced annular ligament, and there will be subluxation of the radial head from it. So how will your patient present to you in the clinic? So they'll have a flexed arm and they'll have a lot of inflammation around it, because all the dislocation and subluxation usually are very painful. Okay, so a patient will come to you and he or she most likely will be crying, and your patient won't let you touch the elbow because that painful. Luckily, as physician, you can mobilize it and again reduce this dislocation back to its original place. But keeping in mind, if once this subluxation has occurred, the recurrence of subluxation is more common in those people. Okay, so if it has happened once, it can again happen again and again, because you have made the annular ligament more flexible. And that brings me to my next clinical correlate. That is, there's a syndrome, there's a pathology called the battered baby syndrome or the shaken baby syndrome. Basically, there's a constellation of signs and symptoms, constellation of findings. So battered baby syndrome, shaken baby syndrome is actually a form of child abuse in which the pediatric population, your patient is basically subjected to physical violence, and it manifests as different signs all over the body. So you can see bruises, and if you perform full body X-ray, you will see a lot of fractures. Some will be new fractures and some will be old fractures that have healed. There'll be fracture of the femur, of the humerus, of ribs. So there can be a lot of. So if you are seeing a child with multiple fractures, the first thing that should come in your mind should be maybe that your patient is being subjected to child abuse. There are other things that also come when we talk about the battered baby syndrome. That is basically, so usually what happens is the brain of the child is still developing and the skull is relatively larger in size. So when you shake the baby violently, so what happens is that the brain shakes inside the skull, and there are a lot of venous structures which also move along with it, and they are prone to get ruptured. So you can actually see intracranial hemorrhages when it comes to battered this shaken baby syndrome. Also, there can be, if you observe the eye through fundoscopy, you can also see retinal hemorrhages. Okay, so what you have to do in clinic, so whenever you are seeing multiple fractures with bruising and MRI reveals bleeding in the brain or retinal hemorrhages, the first thing you have to suspect is shaken baby or battered baby syndrome, and you have to immediately call the child protective services so that they can come and intervene so that your patient is no longer in harm's way. So how do you pick? So these are some signs and symptoms that you can see on the patient, but there are some visual cues which you can see. And one of the major things that you have to look for is that usually those patients, those children who are subjected to violence, they fail to make an eye contact with you since they don't trust their elders. So as a physician, when you talk to them, either they'll be really quiet or they won't make any eye contact with you, and they'll be visibly restless or anxious, or they wouldn't want to talk to you. Secondly, whatever the story that the patient might be saying, your patient might be saying, that won't connect with the story that the parents might have. So the parent might say that he fell down in the classroom, and the child might say that I fell down while playing with my cousins or something. So the stories won't match. These are the first instances when you should be thinking, okay, there's something wrong. And maybe you can also see some hostility between the parents and your patient itself. Just keep that in mind whenever you are doing your primary care clinics. Okay, this is a very common phenomena, and usually it's not reported that much, but you should be cognizant of this fact that this does exist, and this can be really harmful for the physical and social development of your patient. So let's go forward. So with that, we are done with the elbow joint. Now let's come on the cubital fossa. So in our last lecture, we discussed about the axilla. So we talked that all the structure, the neovascular structure, which are coming from the neck region and going down the upper limb, they're actually crossing the axilla. So now we have to talk about the cubital fossa, and think of cubital fossa as a space from which the structures from the arm pass into the forearm. Okay, so this is a triangular structure which is present at the junction of the arm and the forearm. And there's a better image over here. So this is a triangular space. It holds a lot of significance, and we'll see in a while why is that so. Okay, so let's talk about the boundaries of the cubital fossa. So this is the medial aspect of the cubital fossa, and this is the lateral aspect. So medially, we have the medial border of the cubital fossa is formed by the pronator teres, and the lateral aspect is formed by the muscle that is the brachioradialis. The superior aspect is formed by the medial epicondyle. So just imagine, so we have two epicondyle. This is the medial epicondyle. This is the head. So this is the medial epicondyle, and this is the lateral epicondyle. If I draw an imaginary line which will connect both of these two epicondyles, that will be the superior aspect of the cubital fossa. So you can see this imaginary line in blue, which is being drawn between the two epicondyles. This is the superior border. So we are done with lateral, median, superior border. We have the roof. So the roof is formed by the skin on the anteriormost part, then the fascia, then subcutaneous fat, and basically the skin, the fat, the fascia, and the bicipital aponeurosis. And the floor, it's not present well on this diagram, but the floor is formed between the brachialis muscle proximally and supinator muscle distally. Okay. So the boundaries are definitely important when it comes to the cubital fossa, but clinically, what is more relevant is studying about the bursa itself. So we have three bursa located in the elbow region. So we have the intratendinous bursa, we have the subtendinous bursa, and the subcutaneous and olecranon bursa. So we can see over here, we have the subtendinous bursa, which is present between the humerus and the head of the tricep. This is the subtendinous bursa. We have an intratendinous bursa, which is present within the tendon of the tricep muscle itself. And then we have the subcutaneous, which is the superficial most bursa, which is present anteriorly to the olecranon process. Out of all of these, the most high yield bursa is perhaps the olecranon bursa, because since it's the most superficial bursa, so it's more commonly to get damaged or injured or inflamed. Okay. And what is the inflammation of bursa called? It's called bursitis. So you can see we have an image of the basically this is inflammation of the olecranon bursa, and you can see this bulging on the elbow region. Normally we don't have any bulge, but if there is any inflammation because of trauma or infection, there can be a phenomena that is called bursitis. Luckily, what we can do is we can remove the excess fluid. We can use antibiotics, and we can also tap this extra fluid so to relieve the patient of the symptoms. So whenever I think of bursa, I try to think the radiator of my car. So if you remove the bonnet of the car, you'll find a radiator which is present over there, and there's a small bottle which is connected to the radiator. So what happens is, if you pour water in that small bottle, that water will percolate into the giant radiator. The same thing is with bursa. So you have a synovial cavity around synovial cavity containing synovial fluid around the joint itself, but it has connection with these synovial fluid containing sacs, and that is called bursa. So there's direct connection of synovial fluid between these structures. So the bursa has two major functions. So first major function is that it reduces the friction between the structures which are present all around the bursa, because it is a synovial fluid containing sac, so it is really soft. So it actually lessens the friction so that the tricep muscle or any other muscle all around it, it can move freely. And the other thing which is really helpful clinically, that is, since it is connected directly to the joint itself, so if I have to aspirate the synovial fluid from the joint, so I don't have to insert the needle all into the joint, but I can actually aspirate the fluid just from the bursa itself. Okay, so if I want to send the fluid for synovial fluid analysis, so I'll just aspirate the fluid from the bursa itself. Okay, so this is the image which shows that there is basically swelling of the olecranon bursa, and you can aspirate the fluid directly from it. Okay, this is perhaps the most important part of the today's lecture, and that is the content of the cubital fossa. So the structures, so we'll divide the structure which are present medially and laterally, and anteriorly and posteriorly. So this is the medial aspect of the upper limb, and this is the lateral aspect of the upper limb. So medially we have two structure, one nerve and one artery. So medially we have, so this is the medial aspect. So medially we have the median nerve going from the arm to the forearm, and medially we also have a very major artery which supplies the forearm as well as the arm, that is called the brachial artery. The brachial artery actually goes downwards in the cubital fossa, and then it divides into two. So laterally it becomes the radial artery, and medially it becomes the ulnar artery. So you can see we have the brachial artery in red, median nerve in yellow, as well as we have the radial nerve. But this radial nerve is actually present on the lateral aspect. This radial nerve is present on the lateral aspect, anteriorly and laterally. So if you'll contract your bicep muscle, so you will feel its tendon just at the cubital fossa. So this is also where the tendon of the bicep muscle is attaching. Okay. So can you guess what's happening in this image? This is actually dislocation at the level of the elbow joint. And you might think that this is anterior dislocation at the elbow joint, but actually it's the posterior dislocation. Yes, I can see that the humerus is moving anteriorly, but whenever we talk about the dislocation at the elbow joint, we see it in reference to the radius and the ulnar bones. Okay, so you can see the ulnar bone is going posteriorly, so this is posterior dislocation. Okay, again a really high point, that is epicondylitis. We have to discuss about epicondylitis. So we just discussed that we have, so this is the medial aspect, so this is the medial aspect, this is the medial epicondyle, and this is the lateral epicondyle. So there are various muscles, so there are various muscles which cause flexion of the flexion at the wrist and the extension at the wrist. So flexion at the wrist and extension at the wrist. These muscles have a common point of origin. So the flexors of the wrist have a common point of origination, and that is at the medial epicondyle. So I'll repeat again, the flexion of the wrist has a common point of origin, that is at the medial epicondyle, while extension of the wrist, has a common point of origin, and that is at the lateral epicondyle of the humerus. Okay, so usually what happens is, if we are doing a task which involves repeatedly flexion and extension at the wrist joint, so what can happen usually in athletes, what can happen is that the origin of those muscles, that is at the medial condyle or at the lateral condyle, they can get inflamed, and that is called epicondylitis, epicondylitis. So if it's actually happening at the medial epicondyle because of the flexors of the forearm, we'll call it medial epicondylitis. And if it's happening at the lateral aspect, we'll call it lateral epicondylitis. I hope this makes sense. So medial epicondylitis, you'll see in books, it usually happens, it can happen to anyone, but usually most commonly seen in golfers. And so medial epicondylitis usually happens in the golfers, while the lateral epicondylitis mostly happens in tennis players. So how do I remember it? Is that whenever you are making a stroke, whenever you're playing tennis, you have to reach your arm outwards in a lateral fashion, right? So you are moving your arm away from your body, so you are moving it laterally. So that is how I remember that tennis player usually get lateral epicondylitis, and the opposite of that is the golfer's elbow. So usually when you're playing golf, you have to move your arm, in a more medial fashion, rather than in a lateral fashion. That is why that is how I remember that golfer's elbow is medial epicondylitis. Okay, another really high concept, that is supracondylar fracture. And for supracondylar fracture, this is a supracondylar fracture, that is the fracture. So this is the medial epicondyle, and this is the lateral epicondyle, and you can have a fracture just over here. Okay, you can see in this X-ray too that there is a supracondylar fracture. And I said before that whenever a bone is fractured, it has razor sharp ends, and depending on whether those displaced fracture fragment go anteriorly or posteriorly or medially or laterally, there can be damage to various neurovascular structures. So if I see this image, so let's orient ourselves. This is the lateral epicondyle, and this is the medial epicondyle. So if there is a if there is a supracondylar fracture and that piece of fragment moves anterolateral, it moves anterior and lateral, so it will damage what structure? It will damage the radial nerve, as opposed to that piece of fragment, that supracondylar fracture, piece of the bone, if it moves in a medial fashion and anteriorly, it will damage the brachial artery as well as the medial nerve. Okay, and it will have deficits downwards. So we have discussed that we can damage the radial nerve laterally, and we can damage the medial nerve and the brachial artery medially. But there's another nerve which goes on the posterior aspect of the elbow, and that is the ulnar nerve. It's not shown in this diagram, but the ulnar nerve actually arcs in a posterior aspect of the elbow joint and medially. So if the piece of that fracture, if it moves posteromedially, so you can actually damage the ulnar nerve and cause deficits in its region. Okay. So what's this? So for instance, you had a supracondylar fracture and you damage the brachial artery. So what will happen is you will devoid the, so we just talked about that the brachial artery divides into the radial artery and the ulnar artery. So if you damage the brachial artery itself, you will devoid the muscles of the oxygenation and the nutrient supply So what will happen? The muscle of the anterior compartment of the forearm, basically muscle of the forearm will start to die, and in doing so, they will atrophy. And what happens in atrophy? That the muscles will actually shorten. When the muscles shorten, they have their insertions intact. So when the muscles in the anterior compartment, which are actually responsible for the flexion at the wrist, when they will shorten, they will pull the hand along with it. That is why the hand is at a constant flexed posture. It's at a constant flexed posture, and this is called Volkmann's ischemic contracture. This is basically because of the damage to the brachial artery. So as I've written, that the forearm flexor muscle become fibrotic and short, and this is, you can see that there's atrophy going on in the anterior compartment of the forearm. Another high yield point about the cubital fossa is that this is the place where you actually draw the blood. So you have two major superficial veins that there are two major superficial veins which take the blood from the forearm. So medially we have the basilic vein, and laterally we have the cephalic vein. They take the venous supply from the medial aspect of the arm, and the cephalic vein takes the venous supply from the lateral aspect of the arm. But at the cubital fossa, they have an anastomotic process, and that is called the median cubital vein. So if you can see, this is the arm, this is the lateral aspect, and this is the medial aspect. Medially we have the basilic vein, and laterally we have the cephalic vein. And this basilic vein and the cephalic vein is being connected by the median cubital vein, and this is exactly the vein from which, if you have ever gone and drawn blood, so this is actually the place where you actually draw the blood. The phlebotomist draws the blood. Okay. And just the last slide, that is that if you have to measure someone's blood pressure, you can do so by obviously placing a cuff on their arm, but you also have the place where you put the diaphragm of the stethoscope, that is just over the brachial artery, and where that is, it's at the anteromedial surface of the cubital fossa. And with that, we are done. Thank you so much.